Dear students of batch 20, so after having seen the I think hematological disorders, the implications of hematological disorders in your dental practice, today we will see about the implications of hepatological disorders, which are essentially the liver diseases, how they are going to influence our treatment planning, and how we have to handle the patients with an pre-existing illness, which is mainly affecting the liver, and why these liver disorders are of important to us, in what way this is going to affect our practice. Only about these things we will be discussing about, and yeah, we will go into the discussion. So these are all the learning outcomes, which the essence is again customizing your treatment plan depending upon the patient's existing systemic disorders, and then what you should do and what not you should do. Okay, fine. Okay, so why this hepatic disorders is assuming so importance to us? In what way this is going to affect our practice is that we have to know about the drug toxicity, and then in terms of bleeding tendency and the possibility of viral hepatitis. Hepatitis is inflammation of the liver, and viral hepatitis is having a viral etiology. Okay, so we know already about your hepatitis B. You know already how important it is, and why the liver is of so much importance. So we have to be worried in terms of drug toxicity. So certain drugs we may have to avoid, certain drugs we may have to reduce the dosage, and then certain drugs are contraindicated, and certain drugs can be safely prescribed. So if you have a clear-cut idea, when a patient is coming with an hepatic disorder for your clinic, for a practice, I mean for your treatment, then you will be having a clear-cut idea of what to prescribe to this patient, what not to prescribe to this patient. And about the bleeding tendency, which is I think the emphasis of bleeding would have been discussed extensively during the previous lecture, you know very well. And again, you know that any hepatic disorder will cause a bleeding tendency in the patient. That is, there may be prolonged clotting time. So that we have to keep in mind. And then of course viral hepatitis. The patient is infected, and by all means you have to protect yourself from getting the disease contracted from the patient, as well as you have the responsibility of breaking the chain of infection from the patient to another patient. So as an oral healthcare worker, we whom are working closely with all the body fluids. So we have to be very careful in breaking the chain of infection, and then we have to be very careful in adapting to the all infection control protocols, so that the disease transmission is avoided. Okay, fine. So we will just brush up through the applied liver anatomy, the general functions of the liver diseases, and its dental implications. This is what this lecture is going to be about, and mainly we are going to see about the hepatitis bleeding aspects only. Okay, because only both of these things are of much importance to the dental professionals. Rather than going deep into the each and every hepatological disorders, which will be like a general medicine lecture for you, those applied part we will be discussing. Okay. So the liver is the largest internal organ. So it is situated in the right upper quadrant of the abdominal cavity, just below the diaphragm. Okay, so we will see the picture. It's the weight of the liver is around 1.4 to 1.6 kilogram. Okay, the blood supply is by the hepatic artery, which carries blood from the aorta, and then the portal vein carries blood containing digested nutrients from the small intestine to the descending and the descending colon to the liver. So this is the liver. Okay. So you see the liver, you have the left lobe and right lobe, and then you have the gallbladder. The liver secretes the bile, which gets stored in the gallbladder, and depending upon the digestion, I mean food habits, the gallbladder releases the bile, which is secreted directly in the duodenum, and then this bile will help in digestion of the nutrients that we take, especially the fats. The bile is helpful in emulsification of fats. Okay, and then you have the opening. You just know that there is an opening of the bile duct into the duodenum is in close proximity with the head of the pancreas. So what we have to know is that if by case the patient is having pancreatitis, the head of the pancreas will be swollen, and then which can obstruct the opening of the bile duct into the duodenum. So there will be stasis of bile, and because of which the patient may have jaundice as well. So that is an obstructive form of jaundice. So just keep it in mind. So not only the liver per se or gallbladder per se may be infected, but even the infection of pancreas can also present itself like a can be a contributory cause for obstructive jaundice. Okay, this point you keep in mind. So what are the functions of liver? Of course, liver is considered as a factory inside the human body. It only the main function is metabolism. Not only the nutrients are broken into pieces, which can be taken in the form in which the human body can utilize. This is what liver does, and also the toxins are broken up into pieces, and then whichever the I mean to prevent the human body from getting the deleterious effects of the toxins. So essentially the functions of the liver is in protein metabolism, and also it is in the synthesis. Then it also helps in carbohydrate metabolism. You know, there is glucagon is produced, and then it is stored in the liver, and then which releases the glucagon in terms of acute needs. And then there is lipid metabolism through the bile, and the bile is liver actually secretes the bile, with bile salts and bile pigments, which contains bile salts and bile pigments. And then it also produces hormones, certain hormones, and then drug inactivation. Drug inactivation is an important fact of liver. As far as our field is concerned, because we are extensively using lignocaine, the amide anesthetic. The amide anesthetic is being metabolized in the liver, unless like the esters, which are metabolized in the plasma. This amide anesthetic is being metabolized in the liver. So we have to be careful when you are administering anesthetic in a patient who is already having a hepatic disorder. So drug inactivation is an important function of liver, and then it also confers immunological functions also. Okay. So what are the causes of the liver diseases? How all the liver can be affected? Remember, the liver has got a remarkable regenerative capacity. It is not easy to compromise the function of the liver, but of repeated insults, repeated inflammation, and by and large, the alcohol abuse, or more than the alcohol abuse, now they say that drug-induced insults, self-medication, all these can harm the liver to an irreversible extent, in which the liver has lost all its regenerative capacity. So that kind of damage can be made. Though the liver has got a excellent regenerative capacity, it is susceptible to inflammation due to many causes. The one is predominantly you have to know about the viral hepatitis, of which virus is the important cause. It can cause viral hepatitis. You have a variant of hepatitis from A, B, C, D, E, F, G, and like that, of which A is of like a milder form, in which it's called as infectious hepatitis, and then it heals on its own. And then whereas B is of most important to us as dental professionals, which can have which is in the serum, and then it can get transmitted. From patient to patient, or from doctor to doctor, I mean from doctor to patient to patient. And so this extensive strict rules of hepatitis B vaccination is in place. And then hepatitis C is more dangerous than hepatitis B, because there is no vaccine so far. And we have the other variants which is coexisting. Okay, so viral hepatitis, and then the hepatitis because of alcohol abuse or the hepatitis because of drug abuse, and then there is a primary, and there is also a primary biliary cirrhosis. Okay. Other than as such the liver per se, you can have the extra hepatic causes for liver dysfunction because of gallstones, carcinoma of the pancreas. I told you, no, because of carcinoma of pancreas, the head may be increased, and then there may be obstruction. So because of extra hepatic biliary obstructions, you may have problems. Okay. So the main causes, you see, to summarize: alcohol abuse, drug abuse, and hepatitis virus infection are the main causes for hepatic disorders. Okay, fine. So regarding the general management, so how will you know whether the patient is having a having a hepatic disorder or not? So the patient himself will tell you a history of jaundice. Jaundice means yellowish discoloration, right? Yellowish discoloration of the skin and sclera is called jaundice, and then you know that sclera, when it has become yellow, it is called as icterus. Icterus. Okay, so the patient himself will tell you the history of jaundice, and then that yellowish discoloration can happen only when the serum bilirubin level is in the body of more than 50 micromole per milliliter, or 3 milligram per deciliter. Okay, and hence this the vitamin. The liver produces the clotting factors. So when it is affected, the patient will have bleeding tendency. Of course, because of alcohol abuse and drug abuse, the liver can undergo cirrhosis, which is the fibrous degeneration of the liver. It is the point in which the liver gives up its regenerating capacity, and it can cause the liver tumors, hepatocellular carcinoma, and these things. And there may be reaction to medications. There may be a liver surgery in which the patient's liver may have been removed, because many cases the affected lobe is removed, and then the patients may also have received liver transplants, and of course the familial disorders. So how can these patients with liver disorder can present? Just look for these signs when the patient walks inside your clinic, especially when he says that there is a history of jaundice. The patient can have the Dupuytren's contracture, which is the contracture of, say, look at the hand picture, which is in the left side. Okay, then palmar erythema. So palmar erythema, in which there is a reddening of the palm, and then finger clubbing. Finger clubbing means that's like the enlarged, the distal ends of the fingers are enlarged. Then leukonychia, which is the whitish patches on the nails, and then jaundice. There is a yellowish discoloration. And then spider neve, you look at the blood capillaries, which is forming like a spider in the lower portion of the photograph, the third from left. Okay, then gynecomastia, ankle edema, and scratch marks or itching. All these things are clinical manifestations of an existing hepatic disorder. So biochemically, when you test, the serum bilirubin levels are more, aminotransferase enzymes levels are more, alkaline phosphatase enzymes phosphatase is more, and then there is an increased international normalized ratio. INR is being increased. Okay, this INR is very important for us. It is known. It is being used to know it is being done in the patients who are already in warfarin therapy, to know how thin the blood is. That is. Because the warfarin is an anticoagulant, so how far extent the blood is thin, so that which can indirectly tell you the bleeding tendency of the patient. So the same slide which is being re-emphasized here: drug toxicity, bleeding tendency, and possibility of viral hepatitis is what is most the common factors affecting the dental treatment. The bleeding tendency, in which we know that there is the clotting factors are 2, 5, 7, 9, and 10 are deficient in liver disease. There is the PT measures the extrinsic pathway, and the normal range of PT is 10 to 12 seconds. All these things you have studied in the hematological disorders. I believe you would have gone past these diagrams in the hematological disorders. And then in INR, there is a range, which is a ratio of the patient's prothrombin time with the control prothrombin time, actual prothrombin time, and then the range is between 0.9 to 1.2. The average is 1, actually they say the 0.9 to 1.2, and then you can have the INR till 1.5. You know, in the last slide, the maximum permissible limit is I mean, should be less than more than 1.5. So other than the bleeding tendency, we should be careful in prescribing the drugs for liver disease. So the use of any drug in a patient with severe liver disease should be discussed with the patient physician. Of course, this goes by the rule for any patient with an existing systemic disorder. You have to consult the patient. Physician before starting the treatment on these patients. And then hepatic impairment will lead to failure of metabolism of any drugs. So even the mildest amount of overdosage can exhibit as drug tox. Can exhibit as adverse effects in the patients with hepatic disorders, because already the metabolism effect is the metabolic capability is very less. And then in some cases dose reduction is required. In some cases the drug should be avoided completely. So this I have told you in the beginning session. So what are all the drugs which are to be contraindicated, and what are all the alternatives? We will see. So under the analgesics, make a note of it. NSAIDs are contraindicated. So all our the routine prescriptions, ibuprofen or diclofenac, everything should be avoided. And and then the alternatives are COX-2 inhibitors. So, but paracetamol is the one which we prescribe to the patient. Okay. Then antimicrobials, you have this contraindicated with azithromycin, clarithromycin, clindamycin, doxycycline, tetracycline, all amoxicillin, clavulanic acid. All these things are contraindicated, and the safest drugs being our routine amoxicillin, cephalosporin, and penicillin. All these things are indicated. You can safely prescribe these drugs. Okay. Remember, in our renal disorders, we did not contraindicate metronidazole. Metronidazole is a drug which can be safely used in renal patients, but in case of hepatic patients, you have to avoid metronidazole. Okay, right. And then our muscle relaxants, monoamine oxidase inhibitors, all these things have to be avoided. Okay. Then our local anesthetic drug. So you restrict to 2 cartridges per visit for hepatitis and cirrhosis. What they say is that you break the appointment and then give the doses in multiple to avoid sudden overdose of drugs in the patient. So you have to do that, of which they say that this articaine is quite safe when compared to lidocaine. Okay, which is what is given in the textbook. So amide LA toxicity can occur with significant liver disease. The liver disease does not increase the duration of amides. The dental treatment with cirrhosis must be completed over multiple visits to minimize the total amount of local anesthetic used per visit. Okay. And among the anesthetics, you can prescribe paracetamol. But however, in the previous tabular column, it has been mentioned that acetaminophen is contraindicated. It is not like that. You can prescribe the paracetamol. However, you should be reducing the dosage. Okay. However, as a rule, avoid chronic use and use as low dose therapy with the liver disease. Okay. NSAIDs should be contraindicated. Avoid aspirin and ibuprofen with any liver disease. Patients with cirrhosis are at increased risk of kidney damage with NSAIDs. Here they have even recommended the COX-2 inhibitors to be avoided, and instead of that, what they say is that you add hydromorphone for use in liver failure. Okay. So penicillins can be safely used, amoxicillin can be safely used, ampicillin can be safely used, and then you can use even dicloxacillin. Okay. What they say is that in metronidazole, you have to, in case of when you have to treat the anaerobic organisms, instead of absolutely contraindicating, you can use the reduced dosage. Can be used in both of liver and kidney disease, but with a reduced dosage. This in case of only the acute infections in which there is a cellulitis or an abscess, in which you have to take care of the anaerobic organisms. At that time, you can use judiciously the metronidazole. Again, you have this viral hepatitis, the major cause of liver disorders, of which hepatitis A is not so dangerous. It goes clinically mild course, and then it confers lifelong immunity to the patient once the patient acquires the infection. Okay, and hepatitis B, we have to. The oral healthcare workers have to be mostly bothered about, and then the incubation period for hepatitis B is 2 to 6 months, and then jaundice occurs in around 30% of the cases. That is virus. The liver is affected, and then it can have an acute phase for most adults, and then a chronic phase for most kids, because which means that the patient will become carriers when the disease goes for a chronic course. It is mainly contracted by the exposure with contaminated blood and IV drug use, and then there is even a possible of transmission from mother to child, and then there is a high rate of transmission with the promiscuous sexual behaviors, and then you have to use this. The prevalence is universal, and then pediatric patients have this the 90% carrier state. Hepatitis C is one which is more, severe than hepatitis B. Okay, the jaundice occurrence is rare, and the course can be acute or chronic, and then the chronic rate is higher, and then again the exposure is by contact with contaminated blood or IV drug use, and then sexual transmission rate is low. There is universal prevalence, and then it has got a very silent acute onset, and only 5 to 10% patients are asymptomatic, having nausea and jaundice. The patient has a better chance of clearing the infection in the presence of symptoms. Hepatitis C has a high rate of progression, and aggressive progression to chronic hepatitis occurs when there is an coexisting infection with hepatitis B or HIV. And then remember, there is no vaccine for hepatitis C. Only thing you can prevent it by our regular standard precautions that we follow in the dental clinic. So these are all the sequels of hepatitis B infection. Once the virus enters the body, then there may be an onset of acute infection. The patient may recover after having acquired the immunity, or the patient can continue with the carrier state, and then once the patient is receiving the vaccine, we can sufficient amount of antibodies levels are already there, which can prevent a infection of hepatitis B. Okay, so the dental treatment is not contraindicated in the simple or superinfective carrier patient. Just because the patient is a carrier, we cannot defer the treatment for the patient, because by rule, all the oral healthcare workers have to be immunized against hepatitis B. So we have to carefully evaluate the liver function test, and then we have to rationalize whether the patient is under any acute phase or chronic phase of infection, and which case we have to be worried about hepatitis B contraction is by the needle exposure rate, especially the periodontist and then oral surgeons who work extensive or who work with needles. And then because of this higher incidence of needle prick injury in the clinic, 6 to 30%, the hepatitis B is easily contracted. That is why they have made that all the oral healthcare workers should compulsorily undergo immunization against hepatitis B. Once this three dose regimen is completed, you have to wait for 2 months to check the antibody level, which should be around 10 million international units per ml of blood. Okay, and the same goes with hepatitis C, which can also get transmitted with the healthcare workers. Essentially, we have to this hepatitis C has to be prevented, and once hepatitis B is contracted, then you can always have the treatment with immunoglobulins and then interferon and other things. So those things are all there already, but as such, prevention is better than cure. So I think with this we will end of the session. The lecture being mainly concentrating on the bleeding tendency and the chance of getting the viral hepatitis. Okay. Other than that, I suggest you to refer the Causon and Scully textbook of medical problems in dentistry, which will also will give you a detailed detailed aspect of alcoholic and non-alcoholic cirrhosis and other things. But anyhow, at the end point, they will present with bleeding tendency, which matters most of our, for most of our practice, and then this has to be kept in mind. Okay, fine. Thank you.